Okay, everyone, welcome back to the online video lecture series for Philosophy 102 Ethics. Today we're going to be jumping into lecture video 9, which will be a continuation of our discussion of euthanasia that we began in our previous video. Now, what we did in our last video was make a few preliminary points about James Rachel's really famous article, Active and Passive Euthanasia. So remember in that article, what he says he's going to do is he's going to critique the American Medical Association's statement on euthanasia. And so let's remember how he interprets what this statement is saying. So the statement first says that the intentional termination of life is contrary to the values of the medical profession. So the statement first says that what Rachel's calls active euthanasia is never permissible. You can never intentionally terminate the life of a patient. However, the statement also says that you can remove artificial life support from a patient in consultation with that patient's family. And Rachel's calls this passive euthanasia. So, according to Rachel's interpretation, what the AMA statement is saying is that active euthanasia is never okay, and passive euthanasia is at least sometimes permissible. And if you need a refresher on the details between the difference between active and passive euthanasia, you can, of course, see the previous video. But just to sort of give a brief recap, active euthanasia would be something like giving a patient a lethal injection. Passive would involve not doing a surgery that could extend a patient's life or removing a patient from life support. So that brings up the following question. Why think there is a moral difference between actively bringing about death and bringing about death passively? Why does it matter if ultimately we bring about the death of the patient? Why does it matter if we do it in an active way or we do it in a passive way? So in this lesson, we're going to consider two different answers to that question. We're going to consider an answer based on the doctrine of doing and allowing, which we discussed last time, and an answer based on the doctrine of double effect, which we also discussed last time. I'm going to save discussion of the doctrine of double effect for our next video. In this video, I'm just going to focus on this side of things. So, if one wanted to use the doctrine of doing and allowing to support what Rachel calls the conventional doctrine of euthanasia, which is just that active, never okay, passive, sometimes okay, how would one do that? Well, remember, the doctrine of doing and allowing says you need a stronger justification for doing harm than you do for merely allowing a harm to happen. What that also means is, according to this doctrine, actively bringing about death is worse than just merely allowing death to happen. And there's some intuitive support for this, right? As I said last time, directly murdering someone seems a lot worse than just not donating money to charity, which could save another person's life. And one might use that reasoning in this case. You might say, well, a lethal injection, active euthanasia, that's a doing. That is actively bringing about harm. That's an active behavior that causes a death to occur. But something like removing a patient from life support or just not doing a surgery or treatment that would extend a patient's life, that's just passively merely allowing death to happen. And that's why active euthanasia is worse than passive. That's why active is not permissible, but passive sometimes might be okay. So this is the exact perspective that Rachel's argues against in his article. So first, he says the AMA statement uses this reasoning. He thinks the AMA statement relies on the doctrine of doing and allowing. But he's going to argue the doctrine of doing and allowing is false. Therefore, we should also reject the AMA statement. And as he says later in the article, it should be troubling to us that this is guiding medical practice because, in his view, it is causing medical professionals to act in a way that he thinks is morally wrong. Alright, so let's dive into the main argument he uses. And I call this argument the same reasons argument, and here is my outline of it. So basically, here's how the reasoning goes. P1. Satisfaction of the suffering condition and consent condition is sufficient to make passive euthanasia morally permissible. So the first thing we have to think about is, and the reason Rachel takes this approach is somewhat clear, there's more agreement about passive euthanasia. right? So active euthanasia is going to be controversial, but more people are going to be like, yeah, I mean, you don't have to do everything you can to extend a patient's life, no matter how much they're suffering. So more people are going to be on board with the idea that passive euthanasia can be acceptable. So Rachel's invites us to think about, well, why is that? Right? When would passive euthanasia be okay? And the way I explain it is that when we think passive euthanasia is okay, it's because it meets what I'm calling the suffering and consent conditions. Just to put it briefly, passive euthanasia seems okay when the patient says, yes, I'm giving consent, I don't want to be treated any further. Or if the patient can't give consent, then the family says, we don't want to continue treatment any further. And it seems okay when it reduces the total amount of suffering. So when we can stop treatment in a way that reduces suffering for the patient, and we also do it with the proper consent, then people seem to be on board and we say, yeah, passive euthanasia is okay. Okay, so that's P1. But what Rachel's is going to say is that, well, look, if meeting these conditions is enough to make passive euthanasia okay, why isn't it also enough to make active euthanasia okay? So the way I explain P2, if satisfaction of these two conditions is sufficient to make passive euthanasia okay, then satisfaction of these two conditions, suffering and consent, should also be sufficient to make active euthanasia okay. P3, there are some cases in which active euthanasia meets these two conditions, the suffering and consent condition. Therefore, there are some cases in which active euthanasia is morally permissible. So again, if meeting these two conditions makes passive okay, then meeting these conditions should make active okay. That's the basic structure of his reasoning. Okay, so let's go look in more detail at each of these premises. So P1 is, again, just about when is passive euthanasia okay. Let's return, we talked about last time, the case that Rachel's uses with the patient with throat cancer. So let's remind ourselves of this case. To begin with a familiar type of situation, a patient who is dying of incurable cancer of the throat is in terrible pain, which can no longer be satisfactorily alleviated. He is certain to die within a few days, even if present treatment is continued. But he does not want to go on living for those days since the pain is unbearable. So we ask the doctor for an end to it, and his family joins in this request. Okay, so I want to put aside, so let's say you're a medical professional, and let's say, the AMA statement says I cannot engage in active euthanasia. So the patient asks, will you give me a lethal injection? You say, no, that's illegal. It goes against my professional code of ethics. So at that point, what options are left? Well, there are two options. You could withdraw treatment, right? So let's say there's some sort of treatment, or there's some sort of artificial means that we're using to keep this alive, or there's some sort of artificial means that we're using to, as best as we can, deal with the patient's condition. You could take that away. You could engage in passive euthanasia. Or you could continue treatment. You could take the route of life extension. You could do every single thing you can within your power to prolong this person's life as long as possible. Now, Rachel's only point is that in this case, it seems clearly to be the better option, or at least a permissible option, to withdraw treatment. Even if you think it's wrong to actively euthanize this patient, he thinks we'll all agree that it's at least okay to passively euthanize this person. We can at least, we don't have to try to continue to prolong this person's life and suffering as long as possible. If there's some way that we can take away certain treatments that are making their life go on longer than it would otherwise, then we can take those things away. So the only point here is that passive euthanasia, in this case, seems acceptable. All right, so the question then is, well, why is it acceptable? And as I said before, the reason seems to be, well, the patient gives consent, the patient no longer wants to continue their life, and bringing their life to an earlier end than would happen if we continue to try to treat them would reduce suffering. Okay, so these two conditions explain why we think passive euthanasia is okay in that instance. And that's P1. Okay, so P1 says these conditions are enough to make passive euthanasia okay. So P2, and this is really the most important premise, the controversial one, which we'll return to later. And so I'm not going to say a ton about it right now, but what you should be thinking, remember, P2 says, well, look, if those conditions are enough to make passive okay, then any case that active meets those conditions should also be okay. Right? And so the thing you should ask yourself right now is that true? Is there some other important difference between active and passive which should make us distinguish those things? All right, so we're going to return to that. But for the moment, all Rachel's is trying to say is, again, that the same reasons you have for preferring passive euthanasia, you have for preferring active euthanasia. And another way to think about it is this. He says, look, if what you're really concerned with is preventing suffering, if the reason you're engaging in passive euthanasia in the first place is for humane reasons, because you don't want this person to suffer, you don't want this person to feel any more pain that is necessary, then why should you take the route which causes more suffering as a route opposed to the route that causes less? If what you're really concerned about is ceasing the suffering, then active euthanasia would end this person's life quicker. It would reduce more suffering overall. So not only does active euthanasia meet both of these conditions, it seems to meet the conditions even better than passive euthanasia does. Right? And we see in the third premise, he says exactly this. There are some cases in which active euthanasia satisfies both of these conditions. And here's how he explains this. This fact provides strong reason for thinking that once the initial decision not to prolong his agony has been made, active euthanasia is actually preferable to passive rather than the reverse. So once we have gone down the road, we're saying, look, we don't want to prolong this person's agony anymore. We're not going to continue to treat them. We're not going to continue to do everything we can to prolong their life. Then why would we settle just for passive euthanasia? We can prevent more suffering through active. He says, to say otherwise is to endorse the option that leads to more suffering rather than less, and is contrary to the humanitarian impulse that prompts the decision not to prolong his life in the first place. Again, the reason we didn't want to prolong his life was for a humanitarian reason. We thought it was inhumane for him to be suffering this long. So why don't we choose the means that most efficiently and most effectively reduces suffering as much as we can? And that would actually be active euthanasia. And so given those premises, the conclusion he draws is there are some cases in which active euthanasia is morally permissible, namely those cases where more suffering would be prevented. Now, to really bring this point home, Rachel's also considers a second case. So I'll call this the infants with Down syndrome case. I'll read through this and then I'll try to explain the different sort of decision paths that are involved. So Rachel says, in the United States, about 1 in 600 babies is born with Down syndrome. Most of these babies are otherwise healthy, that is, with only the usual pediatric care. They will proceed to an otherwise normal infancy. Some, however, are born with congenital defects, such as intestinal obstructions, that require operations if they are to live. Okay, now, so first, what's going on here? There are certain cases in which two things occur, and these things aren't related in any way. It's just a chance occurrence that both of them are present in the same baby. First, Down syndrome, and second, an intestinal obstruction. Now, the intestinal obstruction is such that it could be alleviated, it could be gotten rid of with a relatively simple and easy surgery. Okay, so those two things are together. Now, sometimes the parents and doctor will decide not to operate and let the infant die. When the surgery is denied, the doctor must try to keep the infant from suffering while natural forces sap the baby's life away. As a surgeon whose natural inclination is to use the scalpel to fight off death, standing by and watching a salvageable baby die is the most emotionally exhausting experience I know. It is easy at a conference and a theoretical discussion to decide that such infants should be allowed to die. It is altogether different to stand by in the nursery and watch as dehydration and infection wither a tiny being over hours and days. This is a terrible ordeal for me and the hospital staff, much more so than for the parents who never set foot in the nursery. Alright, so let's take a look at what is going on here. So in this case, we have the first decision we have is, should we perform the surgery or not perform the surgery? If you perform the surgery, then the outcome is that the infant lives, and they go on to have an otherwise healthy, normal life, with the exception of having the Down syndrome. If you do not perform the surgery, however, then the decision has been made at that point that the infant will die. That is the decision that has been made. Now, my first comment about the first decision is you could, of course, have a serious ethical discussion about what the best thing to do here is, or whether parents should be permitted to choose not to have the surgery. Right, it seems clear in this case the only reason that parents would not be having the surgery is because of the diagnosis of Down syndrome, and this would obviously be a very controversial issue. But I'm going to put that aside just because Rachel says his purpose in this article isn't to say anything about this first decision. He says, I can maybe see arguments on both sides, but that's a discussion for another day. What he's concerned with is, what happens when this decision is made? If the decision to not perform the surgery and to and thereby to bring about the death of the infant, if that decision is made, then what do we do from there? Okay, well now we have a second decision. We know we're going to bring about the infant's death. Are we going to do it passively, or are we going to do it actively? Now, if a medical professional follows the AMA statement, if they follow the ethical guidelines of the profession, they are not allowed to perform active euthanasia. They would not be allowed to give a lethal injection to this infant, which would mean their only option would be to engage in passive euthanasia. And that would mean that the outcome that results is that the infant suffers and dies. And Rachel says, the doctrine that says that a baby may be allowed to dehydrate and wither, but may not be given an injection that would end its life without suffering, seems so patently cruel as to require no further refutation. The only reason the medical professionals will be forced into this outcome is because the AMA statement says active euthanasia is not allowed. And notice that if active euthanasia were allowed, the infant would die painlessly. So Rachel's whole point here, again, is not to vindicate that this is the right decision to not perform the surgery. Maybe it is, maybe it's not. Maybe the parents should be allowed to decide, maybe they shouldn't. His point is just that once this decision has been made, clearly the right choice, in his view, seems to be active euthanasia. And so, in his view, that means there must be something wrong with the AMA statement. There must be something wrong with the view that active euthanasia is never okay. Alright. Now, at this point, there's still a sort of issue that's outlying. And that issue is the following. I told you earlier that the most controversial premise of this argument is the second one. Because the second premise says that, look, if passive euthanasia reduces suffering and is consented to, and that's enough to make that okay, then in any case where active euthanasia reduces suffering and is consented to, should make active euthanasia okay. P2 relies on the idea that there's no inherent moral difference between passive and active euthanasia. And this is known as, philosophers call this the bare difference thesis. Compare any two cases, X and Y, in which the only relevant difference between them is that X is a doing and Y is an allowing. There will be no way to make a moral distinction between these cases. That is, the bare difference between doing and allowing is not morally relevant. So remember, active euthanasia is a doing. Passive euthanasia is seen as an allowing. And Rachel says, yeah, that's true, they are different in that respect, but there's no important difference between doing something that brings about death and allowing death. They're exactly the same in and of themselves. And the way he argues for this is he employs a strategy where he draws a contrast between the following two cases. And philosophers now refer to these cases as the wicked cousins. Okay, so let's look at the first wicked cousin case, Smith. Smith stands to gain a large inheritance if anything should happen to his 6-year-old cousin. One evening, while the child is taking his bath, Smith sneaks into the bathroom and drowns the child, and then arranges things so it will look like an accident. Okay, now let's compare that to Jones. Jones also stands to gain if anything should happen to his 6-year-old cousin. Like Smith, Jones sneaks in, planning to drown the child in his bath. However, just as he enters the bathroom, Jones sees the child slip and hit his head, and fall face down in the water. Jones is delighted. He stands by, ready to push the child's head back under if it is necessary, but it is not necessary. With only a little thrashing about, the child drowns all by himself, accidentally, as Jones watches and does nothing. Okay, so when you compare these cases, the first question to ask yourself is, in either of these cases was the action morally permissible? That is, in either of these cases, do we look at Smith, do we look at Jones and say, oh, what they did was just fine? Well, of course not. When you hear that Smith drowned his 6-year-old cousin to gain an inheritance, you say, what a horrible thing to do. When you see that Jones simply stood by and watched his cousin drown to gain inheritance, you say that's also a horrible thing to do. Especially given the fact that, of course, Jones had every intention of drowning his cousin just as Smith did. The only reason that Jones didn't drown his cousin is because he didn't need to. It just so happened that the cousin slipped and fell and drowned all by himself. Okay, so what does this show? Well, let's break this down. The way he's thinking about this is that, and first to be very clear, he's obviously using this as a comparison with active and passive euthanasia. He's not claiming that medical professionals are anything like these sadistic killers. He's focusing on another aspect that's common. Smith's action is similar to active euthanasia, in the sense that Smith actively moves his body to bring about the death of the cousin. Jones, on the other hand, is more similar to passive euthanasia. Jones just sits by and watches. There's something he could do that would save the life of the child, that would save the life of his cousin, but he simply decides not to do it. So, Smith is engaged in a doing, Jones is engaged in an allowing. And the point Rachels wants to make is that when we evaluate these cases, we don't let either of them off the hook. Here's how he explains this. Did either man behave better from a moral point of view? If the difference between killing and letting die were in itself a morally important matter, one should say that Jones' behavior was less responsible than Smith's. But does one really want to say that? I think not. In the first place, both men acted with the same motive, personal gain. Both had exactly the same end in view when they acted. They wanted their cousin to die to gain the inheritance. Moreover, suppose Jones pleaded in his own defense, after all, I didn't do anything except just stand there and watch the child drown. Again, if letting die were itself less bad than killing, this defense should have some weight, but it doesn't. So his point is that if Jones defended himself in court and said, all I did was let my cousin die, we wouldn't see that as exculpatory. We wouldn't see that as an excuse. And notice the ways in which these cases are precisely the same. Smith and Jones both had a motive of monetary gain. They both intended the same outcome, the death of their cousin. That's how they were going to gain, that's how they were going to achieve their monetary gain. The only difference between them is one was a killing or a doing, one was a letting die or an allowing. And if we look at Smith and Jones and we say they're both equally evil, they're both equally bad, then in Rachel's view, this suggests that the difference between killing and letting die must not be morally important. It must not actually matter. And so, for this reason, this is how he supports premise 2 of the previous argument. Let's just recall to ourselves what that is. Right? This premise, which relies on the fact that passive and active euthanasia are both inherent, there's no inherent difference between them. As long as a patient consents to the choice, and as long as the choice brings about less suffering, it should be done. And it doesn't matter whether we're bringing about death through passive or active means, and if active means can bring about less suffering overall, then that's the choice that should be made. Now, of course, when you're thinking about this argument, the question you should really ask yourself is the following. Is there any morally relevant difference between these two cases that Rachel's isn't recognizing? Is there something between those that is different that actually explains why doing and allowing matters from a moral point of view? Okay, but let's say Rachel's is correct for a moment. Let's just imagine that's the case. Obviously, there's more debate to be had, but let's imagine he's correct. What are the implications of this? And this is the way he sort of states his conclusion. If a doctor lets a patient die for humane reasons, he is in the same moral position as if he had given the patient a lethal injection for humane reasons. Now, if that's the case, then one implication is that the AMA statement on euthanasia is incorrect. Intentionally terminating the life of one human being is not necessarily contrary to the policy of the medical profession. If the medical profession is concerned with health, with preventing suffering, with encouraging flourishing and happy lives in patients, then if those are the purposes of the medical profession, then there's nothing inherently against those in active euthanasia. Active euthanasia may very well best serve the end of preventing more suffering. So one implication of Rachel's argument is that this statement is incorrect. And as he says, it's forcing doctors to behave in ways he thinks are immoral by causing more suffering than is necessary. Another implication of this is more general, just outside of the medical realm itself. For many people in many moral systems, a foundational bedrock claim about morality is the following, which I'll call the traditional prohibition on killing. It is always morally impermissible to intentionally kill an innocent person. When you think about some foundational moral rules, you might say, well, don't lie, and don't steal, and don't kill. And sometimes don't kill is cashed out in this way. Don't intentionally kill an innocent person. But in fact, if Rachel's is correct, then this traditional prohibition on killing is false. Sometimes it is permissible to intentionally kill a person who's innocent. Remember, the patients were not saying that their death is brought about by something they've done wrong. They're a completely innocent person. It's just because they've consented to it and would like to reduce their suffering overall. And this also shows you, in an important way, how Rachel's is taking a consequentialist approach. The intent with which you act, the means by which death is brought about, those aren't really important. The fact that this traditional prohibition on killing has always been a bedrock rule, moral rule, many societies have seen it as just foundational, that doesn't really matter either. What does matter for Rachel's is that there are situations in which active euthanasia can bring about the best consequences. And bring about the best consequences in terms of promoting pleasure and more specifically of reducing pain. So here we see how the consequentialist point of view is again going to give you some results, just like, last week we saw, well, the utilitarian or consequentialist view sort of upends the traditional view of animal ethics. It might upend the traditional view of giving to charity. Now it's also upending the traditional prohibition on killing. It is not always wrong, according to a utilitarian or consequentialist, to intentionally kill an innocent person. Okay, so I'm going to stop there. We will get to Sullivan's article in our next video. As always, thank you for watching, and I'll see you next time.